Hi guys, welcome back. Now we shall be talking about a topic by the name of cystic fibrosis. It is also alternatively also called as mucoviscidosis, where the secretions in the body, especially the ones with relation to the pancreas, are very thick and viscid, and that contributes to myriad manifestations that I'll be explaining to you today. Now, in this condition, Harrison is using a term by the name of exocrinopathy. That is because of this particular condition having a propensity to involve the exocrine glands in the body. Now, there's a diagram which is given here, but instead of explaining the diagram, I'll just try to simplify things before you. So, first and foremost, this is a genetically acquired condition related to autosomal recessive pattern of inheritance. So, consanguineous marriage could be given in the question. The chromosome which is faulty is chromosome number 7, on which there is a problem with respect to a gene which expresses a protein by the name of CFTR. So the gene that we are talking about is also called as CFTR, and the protein that it will express is also referred to as CFTR protein. The full form of CFTR would be cystic fibrosis transmembrane conductance receptor. Now, when it comes to this gene, we have studied that this would be having 1480 amino acid sequence. In this particular sequence, phenylalanine is present at position number 508. What happens in cystic fibrosis is that this phenylalanine at 508 position is deleted. And that is why you would have read in the textbook that the most common mutation, though there are about 1000 mutations which are documented for cystic fibrosis, he says that the most common mutation is F508 mutation, which basically means the fact that there is deletion of phenylalanine at 508 position. Now, how does that cause so much of myriad manifestations is definitely an enigma to medical science, but we have been trying to solve this puzzle for a fairly long time, and now we have answers that this CFTR protein malfunction would contribute to development of multiple manifestations in the following sense. So let us take this to be a representation of a cell with respect to the respiratory system. We know the fact that our lungs have ciliated columnar epithelium, a pseudostratified ciliated columnar epithelium, and all cilia beat in same direction, so we call it a mucociliary escalator. There's a disease by the name of Cartenegger syndrome, the problem with which is that there is a defective motility of the cilia, or they are in fact immotile due to dynein arm malfunction, but to them talking about the cilia being normally motile. Now we can take this to be a representation of a chloride channel, let me say. So we on this side will be having chloride, we'll be having bicarbonate, and we have is water, and all of this is supposed to go out like this into the periciliary area. The cilia of ours are immersed in what is called as PCl, that is periciliary fluid, and this periciliary fluid has to be kept hydrated, and therefore the relative liquid consistency of the periciliary fluid ensures normal motility of the cilia. Superiorly, I have also shown here presence of mucus. So we have mucus which is coating our entire respiratory epithelium. Below it is the periciliary fluid, which is obviously to be hydrated. What happens in cystic fibrosis is that there is a malfunction of this CFTR, that is cystic fibrosis transmembrane receptor. So I'm just putting a cross here to say that the chloride will not be able to go out, bicarbonate will not be able to go out, and even water will not be able to go out. So the implications for the patient would be that the periciliary fluid will be having less water, and that basically means that there is dehydration in the periciliary fluid, so the secretions will become relatively thick and viscid, and that's why I began the topic by describing the word mucoviscidosis. The secretions are thick and viscid, so the clearance is affected, and that is why lungs are rather the first organ to be affected in this particular condition. So cystic fibrosis as a disease, why they call it cystic fibrosis? Because initially they found that this condition will be having cysts in the pancreas, because the pancreatic acini are not able to produce the pancreatic juice. The pancreatic secretions are dehydrated. You in this condition rather have a shrunken pancreas. There's a replacement of the pancreas by the fibrofatty tissue. So let's just make a list of important organs in the body which would be involved in this condition, starting from lungs, then The GI tract is obviously involved. Then in these patients, the pancreas is involved. In fact, the pancreatic involvement in long run can also result in development of diabetes mellitus in the patient, which would be called as secondary diabetes mellitus, because the problem started from cystic fibrosis, damaged the exocrine component. Due to the shrinkage in the size of the pancreas, even the islets of Langerhans are involved. So the beta cell production is compromised, and therefore type 2 diabetes can be developing in the patient. The exocrine production of the liver is the bile, so these patients can be having biliary stasis that can contribute to biliary cirrhosis in the patient. So these are some of the important organs apart from genitourinary system which are involved in this patient. So let's go step by step and understand what is actually going on due to this cystic fibrosis protein malfunction. As I said, the root of the evil in this particular condition will be one, that there is a low water content of the PCL, that is the periciliary fluid. Second, because bicarbonate is also not able to go out, so he also says in the textbook acidic environment of the periciliary fluid. I repeat my statement again. Why acidic environment? Because bicarbonate is not able to go into the periciliary fluid. He says due to the combination of the low water content as well as the acidic environment of the periciliary fluid, the mucociliary clearance that should happen like normal is hampered. I would once again like to highlight the fact that if it was Cartenegger syndrome, I would have straight away started by saying the problem is with the cilia. But as you can see, in this condition, the motility of the cilia is perfectly normal till the disease occurred. The problem is not with the motility of the cilia, it is the mucus which is rather dehydrated, the mucus which is thick. So mucociliary clearance in this patient is hampered, which means the fact that the clearance of inhaled bacteria, the inhaled bacteria which are the troublesome bacteria in this condition are like Staph aureus or Pseudomonas or Burkholderia cepaci. I mean, they're really nasty organisms, and then these organisms can thrive very well. On a comparison scale, if he says first organism to colonize the lungs, it is usually Staph aureus, but gradually it is replaced by Pseudomonas. The Pseudomonas aeruginosa is a very nasty organism. What it does is that it undergoes a mucoid transformation. The importance of knowing this mucoid transformation is that this organism, once it undergoes a mucoid transformation, it can form a biofilm in the lung. Biofilm is going to be impervious to antibiotics. So I would say like this is like a science fiction movie that you are having a villain but you can't hit it because it's having a security cover. This bacteria will form a biofilm by which the antibiotics are not able to penetrate, due to which the ultimate problem in these patients would be thick tenacious secretions in the lungs, and the antibiotics are not able to go through. I mean, you are sending in the security team and they're not able to get access to the bad guys. That's the basic fundamental problem in these patients, and therefore you would be having bronchiectasis, large airway disease, and a productive cough developing in these patients. Once we have gone through the basic genesis of the disease, we will now try to practice regarding what are the pathological features related to the development of cystic fibrosis. The first and the foremost is the involvement of the lungs of the patient. The involvement in the lungs will start by first development of bronchiolitis. There is a follicular plugging of the airways by tenacious secretions. To explain those tenacious secretions, I can say, like if you wake up with a dry mouth, like suppose you were sleeping very deeply with your mouth partially open, so it might have happened in your life that when you woke up you found your mouth was very dry, and then you try to move your tongue around, how it feels, it's all sticky, it's all rather slow. So similarly here, what I'm saying is, because the airways are having a thick tenacious secretions, so the clearance is definitely hampered, and the bronchiolitis that occurs in these patients then upgrades to bronchitis. Very soon in these patients, the large airways become filled with pus. I'm talking about large dilated airways filled with pus, that is development of bronchiectasis. And obviously, recurrent pneumonia usually causes death in Indian patients before the first year of life because of lack of medical care in our country. But in America, where medical care is good, you might have these patients surviving up to the adult age group. So lower respiratory tract is definitely involved in these patients. In fact, even upper respiratory tract involvement is found in these patients in the form of presentation of mostly nasal polyps. So most of the time what will happen in this condition would be presence of sinusitis. It could be written as recurrent sinusitis. So even Cartenegger syndrome has written recurrent sinusitis, but polyp feature is usually not given, and these polyps will contribute to, I would say, nasal stuffiness in these patients. Therefore, nasal polyposis as a feature could be written in a multiple choice question of cystic fibrosis and should be remembered. The hallmark feature of this particular disease, especially related to the GI tract, especially related to the pancreas in the patient, will be that the pancreatic juice is also very thick and viscid. So therefore, it rather causes, it's not able to come out and it causes local damage in the pancreas. So in these patients, the size of the pancreas becomes relatively smaller, and most of the pancreas is replaced by fibrofatty tissue. The importance of knowing this is that the pancreatic secretions are definitely compromised in these patients. So therefore, the pancreatic amylase concentration in the intestine will be less. Pancreatic lipase concentration in the gut will be less. So malabsorption syndrome can occur in these patients, and therefore failure to thrive and failure to increase weight. I mean, one of the primary concerns of a mother of cystic fibrosis will be that the child is not gaining weight. So malabsorption syndrome could also be described in the question, apart from nasal polyposis. Then the liver is involved. You can see the greenish representation that I've shown here. These patients will end up with development of biliary cirrhosis. Once they end up with biliary cirrhosis of the secondary variety, then there could be features like obstructive jaundice written in the question, or rather these patients might be having prolongation of physiological jaundice. It might look like our standard physiological jaundice initially, but then it will deteriorate further, and you would be having a possibility of clay-colored stools in these patients, extensive itching, pruritus. All the features of obstructive jaundice manifestations could be occurring or could be written in the question. Therefore, these patients might require even a liver transplantation for the same, and they might even require lung transplantation for the same. So, organ transplantation may be done in these patients. When it comes to the GI tract per se, the esophageal glands and the duodenal glands, like in the duodenum, you have crypts of Leiber-Cohen, where you have Brunner's glands. So all these glands are also going to malfunction, and they are mainly filled only with mucus. Their normal secretions is not there, and the end result for this would be that the Brunner's glands are not able to neutralize the acid coming from the stomach. So therefore, incidence of epigastric pain and duodenal ulcers can also occur in these patients, because normally Brunner glands produce alkaline secretion, which is going to neutralize the acid coming from the stomach, and that will definitely not happen in these patients. Before I go to the next manifestation, I would like you to use this opportunity to remember a MCQ by the name of primary biliary cirrhosis. The word one means primary biliary cirrhosis, which is autoimmune, and the antibody responsible for primary biliary cirrhosis is called as AMA, that is called as anti-mitochondrial antibody. AMA is anti-mitochondrial antibody. This is primarily responsible for primary biliary cirrhosis, but for cystic fibrosis, answer it as a secondary biliary cirrhosis in a patient. And if he says what is the most common organ involved in this condition, then it is lungs, which are involved in most of the cases. Both lower and upper respiratory tract involvements can be seen in these patients. The next involvement that you will encounter in these patients would be genitourinary system. Now, from the perspective of the genitourinary system, one, I would like to tell you the fact that the cervical mucus, like you would have read about spin barkate, which is that the cervical mucus thins out on the 14th day of the cycle, that is at the time of ovulation, that is to facilitate the entry of sperms. In a woman with cystic fibrosis, there will be very thick and tenacious cervical mucus. This thick tenacious cervical mucus will form a cervical mucus plug, and that plug will occlude the opening of the cervix. So if I represent like this the thick cervical mucus plug, then the entry of sperms would be hampered, and therefore ability to conceive would definitely be a problem for this patient. So a female with cystic fibrosis, that is if she survives into adult age group, then conception issues or infertility could be described in the patient. Once she conceives by any artificial reproductive technique, then her pregnancy is gonna go fine. And if you ask me, or if as a doctor you are asked per se that can a girl with cystic fibrosis ever be a mother, then your answer will depend upon her lung function. Because let me say, if she is having lung function so bad that she is even breathless and going to the bathroom, then she cannot obviously be a mother. She will die at the time of delivery. So based on the lung function report, we will say that pregnancy is or is not possible. Like I said, right from childhood, good medical care was provided to the patient in the form of regular tobramycin nebulizations. Tobramycin nebulizations on weekly basis, like they do in America, prevents the colonization of the airways of these patients with the harmful bacteria. So that can prevent, once the colonization is prevented, obviously the lung profile will be better, so person can conceive. But like I said, if the lung function is bad, then the pregnancy would be contraindicated. So I've written plus minus to say pregnancy can happen, but is directly related to lung function report, pulmonary function testing report in the patient. And if you have low FEV1 values, you are having a shrunken lung in the patient in the later on. Initially they have obstructive airway disease, but later on they develop pulmonary fibrosis. So if you are having shrunken lungs with decreased residual volume, then pregnancy is a big no for these patients. From the male perspective, I wanted to remember that sexual function. What I mean by sexual function is that ability to get an erection or to have an ejaculation is normal in this condition. So a boy with cystic fibrosis will be able to have normal erection and ejaculation, but will be having azoospermia because there is agenesis of vas difference. In fact, this is the most important statement that I want you to remember for the topic of cystic fibrosis from medicine perspective, because most of the time this pointer will always indicate that we are not studying about Kurtenegger syndrome, because Kurtenegger syndrome we usually get infertility in a male patient primarily because of the motility of the sperm being defective. But here I'm not talking about problems with the motility of the sperm. I'm talking about agenesis or vas deferens, and even agenesis or malformation of the epididymis would be present. Even the seminal vesicles are not developed properly in the patient, so the basic infrastructure with respect to the sperm transport would be hampered in this condition, and therefore the final result for a male patient of cystic fibrosis would be development of azoospermia. Infertility as a word will definitely be written in a multiple choice question with respect to cystic fibrosis. So let's revise the pathological aspects for the disease. The pathological aspects for the disease would be lung involvement ranging from bronchiectasis to small airway disease, sinusitis, a small pancreas, shrunken pancreas in the patient contributing to malabsorption syndrome, and in fact in these patients by the second decade of life, because the pancreas will be replaced by all the fibrofatty tissue, so diabetes mellitus manifestation can also occur in the patient. The liver produces bile. The bile release is defective, the bile is thick, it is stuck inside the pancreatic duct, and lots of these patients might even be having absence of the cystic duct. So remember this additional point also, absence of vas deferens and absence of cystic duct could be present in patients of cystic fibrosis, contributing to biliary stasis or biliary cirrhosis, contributing to obstructive jaundice manifestations in the patient. And it is no big deal that because I'm saying cirrhosis, he might even start writing about features of portal hypertension in the patient like varices and capillary. So obviously the pathological part will tell you the fact that there could be manifestations of our decompensated cirrhosis occurring in the patient. And infertility is explained here with respect to agenesis of the infrastructure related to the transport of the sperms or the cervical mucus plug. So once we've done the pathology, we'll next talk about clinical manifestations of the disease. And the first clinical manifestation is very striking in these patients. As you can see, the prominent bronchiectasis. In fact, I've shown two images of the same patient. You can notice a horrible looking X-ray in the patient where you can see these tram track appearances. You can see the saccular dilatations of the large airways of the patient. So this is itself an image-based question for you, bronchiectasis, and they can ask you regarding etiology of bronchiectasis, though there are many of them, especially if it's a teenager with bronchiectasis, purulent sputum, then we have to think in terms of cystic fibrosis as a possibility. You can see the dilated airways and dirty appearance of the lungs, especially one of the dilated airways in the upper airways very prominent, and we can highlight our tram track appearance for these patients. Therefore, let's just summarize the important clinical features of this disease. Let us now discuss the clinical features of this disease. The first one would be presentation of chronic cough in a patient, which would be productive in nature and would be purulent. So, foul smelling pus can be described in the MCQ. As the disease will progress in the patient, there could be development of shortness of breath in the patient, or dyspnea on exertion could be written. Because in these patients, the lungs are involved, ultimately the heart will also get involved because patient will develop cor pulmonale. Meaning of the word cor pulmonale is right ventricular failure due to a non-cardiogenic cause. So the non-cardiogenic cause that we're studying here is cystic fibrosis causing damage to the lungs in the patient. So features of right ventricular failure like elevated JVP and pedal edema could be described in the patient. In fact, cystic fibrosis is one of the important reasons for need for lung transplantation. One of the number one cause of lung transplantation bilateral is cystic fibrosis. For unilateral lung transplantation, it is mostly emphysema, but for bilateral lung transplantation, cystic fibrosis is one of the important causes. On physical examination, these patients initially will be having symptoms of obstructive airway disease. So AP diameter will be increased in the patient. AP diameter of the chest would be increased in the patient. Like in emphysema, you read about a barrel-shaped chest. These patients could be having features of obstructive airway disease like hyperresonance in the chest, or increased anterior-posterior diameter of the chest, or there could be a presentation of clubbing in the patient. That is, on the long run, clubbing is anyway a feature that is seen with bronchiectasis. And if he gives you a case where there is a sudden deterioration in the clinical profile of a patient of cystic fibrosis, in a sense that there is sudden onset respiratory distress so bad that he is having cyanosis, then one of the possibilities which is to be considered is pneumothorax. Second, he can say there could be sudden deterioration in the form of development of hypotension. That is because these patients could be having purulent lung disease causing massive hemoptysis, and the massive hemoptysis that will occur subsequently will contribute to manifestation which will cause maybe a drop in the blood pressure of the patient. So especially if he's talking about sudden onset respiratory deterioration of the patient, or if he's talking about hemodynamic compromise in a patient, then these two differentials are the ones that you should keep in your mind, especially in patients who are having cystic fibrosis, or even emphysema patients. If they're having a sudden deterioration, it could be due to pneumothorax, though hemoptysis is not found in emphysema. We get lung manifestation as the predominant manifestation of the patient. Other features could be in the form of nasal stuffiness. And now we are going to talk about the GI manifestations of the patient, as you can see in the image. This was a newborn baby with cystic fibrosis who was brought in a hospital, and he was having abdominal distension. So you did an X-ray of the abdomen. You can see multiple air fluid loops present in this particular child, and you ask the mother, has your child passed stool? And she says, no, doctor. Delayed passage of meconium or non-passage of meconium is a presentation in cystic fibrosis. Meconium is the first stool of the baby. Normally, you know the fact that meconium should be passed within 48 hours. But in this patient, 2 days have gone by, 3 days have gone by after birth. This is a newborn baby having abdominal distension. Like the mother says, first day of life he was taking feed well. Second day of life he was taking okay. But then third day he is not taking the feed. There is a gross abdominal distension. And when you asked her, did your child pass a blackish, greenish color of stool? She says, no doctor, my child does not pass stool. That means definitely there could be anorectal malformations, as you know from pediatrics. So you can refer to the pediatric section for causes of delayed passage of meconium, including Hirschsprung's disease, is to be studied apart from anorectal malformation. But the third important reason after anorectal malformation and Hirschsprung's disease is what we're studying right now. That is, the meconium in these patients could be insippisated in the colon. Why that happens is because normally the meconium, that is the first stool of the baby, is in liquid consistency, and pancreatic juice and pancreatic secretions keep the meconium in liquid consistency. But here the pancreatic juice is not able to come out, so the meconium tends to solidify, and therefore the presentation of this particular patient would be that of meconium ileus. So GI problems in the form of meconium ileus can develop right in the first few days of life of this patient. In the exam, he can ask you regarding what is the investigation of choice for meconium ileus. Do not answer a barium anemia, which can cause water intoxication. So in little babies, we do a gastrogafin anemia. If he says what is the treatment of choice for this condition, the treatment of choice for this condition is also gastrogafin anemia. Why? Because anemia will draw in water. It will soften the stool, because this meconium is hardened, it is stuck inside the colon. If you soften the stool, it is usually expelled. So meconium ileus baby is lucky in a sense that the diagnostic technique that we are using will also help in excretion of the hardened stool inside the colon. So most of the time the child will be sent back home with obviously more problems to occur in his subsequent life, but at least at this time he has made a victory. So meconium ileus is an important point to be remembered for the topic of cystic fibrosis. This is not going to come out, and pancreatic juice contains amylase and lipase. If amylase will not come, sugar will not be absorbed. If lipase will not come, then steatorrhea will definitely happen. So in these patients, there is a malabsorption with respect to sugar. Why I'm saying malabsorption? Because these patients are having a less pancreatic amylase in the blood because the pancreatic secretions are stuck in the pancreas, the thick we said. So there would be osmotic diarrhea developing in a patient. There would be a steatorrhea that would be developing in the patient. So failure to thrive or protein energy malnutrition are the features that could be written in a multiple choice question. Because fat soluble vitamins will also not be involved, he can deliberately in the question introduce features of vitamin E and vitamin K deficiency, which are quite frequently found in these patients. Vitamin E deficiency can contribute to development of a hemolytic anemia by formation of abnormal RBCs that are called as acanthocytes. And vitamin K, you are knowing that is important for formation of gamma carboxylation of 4 clotting factors 2, 7, 9, 10. So bleeding in the form of purpura could be present in these patients. So this child could be a malnourished child. You might think he's having cystic fibrosis, he's having anemia, he's having bleeding. It's a child of a malabsorption syndrome, but concomitant lung infections in a patient, the previous history of meconium ileus, the sinusitis component in the patient will definitely give you clue that we are not talking about only celiac sprue. More problems that will occur in this patient will be involvement of the liver contributing to development of cirrhosis of the liver. Therefore, apart from icterus, because there could be decompensated cirrhosis, he could talk about ascites, enlargement of the spleen, and then the spleen will start destroying the RBC, WBC and the platelets contributing to hypersplenism. Development of caput medusae in the patient or development of bleeding varices in the patient. That would be a little far-fetched, but yeah, we do read about varices with respect to patients of cystic fibrosis can also occur in the patient. So if you read the question carefully, there is no reason why you will mess it up with celiac sprue, because celiac sprue will again be a child and will be having features of malabsorption syndrome, but you don't read about cirrhosis in celiac sprue. You don't read about having development of lung disease so bad that it is contributing to clubbing, it is having a requirement of lung transplantation, and you obviously don't read about our previous history of meconium ileus, except for obviously this topic. Meconium ileus is a characteristic feature that is found in cystic fibrosis only, and the most common organ involved in the body, however, is the lung. From the genito-urinary system perspective, I have explained to you the reason why infertility will also be a feature. Do remember for a male, and I'm emphasizing again, that is age and SS of vas deferens is the main reason why these patients could be having this manifestation. For point number 8 of the discussion, I want you to give maximum attention. Why? Because when it comes to sweat glands in the patient, the malfunction is slightly different from what normally happens with respect to the lung or the liver or other secretions in the body. You see, sweat will obviously be a cooling mechanism for the body. The sweat contains water, it contains salt, it also contains chloride. And when you and me have sweating, the water part is obviously the major component of the sweat. It contains a little bit of salt and little bit of chloride, because most of the time the salt and the chloride reabsorption occurs. So your and my sweat will be having very little amount of, I would say very limited amount of salt and chloride. Obviously, you know, like if we talk about a cricket player, let me say there's a cricket match going on in Sharjah. Sharjah is in close to Dubai. Now, a hot environment, right? At 50 degrees Celsius, if the cricketer like Virat Kohli is going to do running, he is going to lose salt from the body, he is going to lose water from the body, so there can be muscle cramps. So you would have seen athletes, badminton players, or let me say tennis players ending up with muscle cramps due to heat exhaustion, due to heat dehydration, and the sweat that is lost from the body also causes loss of salt. But when I'm not talking about athletic activity, like you and me are sweating, right in the hot Indian summer, if you and me are having sweating, our salt will be losing mainly water and very little salt and chloride, because in a normal person what happens is that the sweat would be having obviously water in substantial amount. The sweat is water after all, but then it will be having limited amount of salt and chloride. Why? Because reabsorption takes place. In cystic fibrosis, what happens is that the absorption of salt and chloride both is inhibited. The salt and chloride reabsorption both is inhibited. Now why this is important for you to understand is because when I was talking about lungs, then when I started this class, I started this word that in patients of cystic fibrosis, when it comes to especially the lungs or the GI tract, what happens is that the chloride that is normally entering into the periciliary fluid is inhibited. So less chloride, less bicarbonate, and less water results in a periciliary fluid dehydration. But in patients who are having cystic fibrosis, when it comes to the involvement of the sweat glands in the patient, then what happens is, like, let me say this is the ductal lumen of the sweat gland. In a normal person, what happens is that the chloride is reabsorbed via CFTR. We have a ENaC, epithelial sodium channel. So you can see the CFTR, you can see here the ENaC, that is the epithelial sodium channel. Remember, I've taught you epithelial sodium channel even in the kidney. So CFTR and the ENaC are present in the sweat glands also, and they actively take back the chloride and they actively take back the sodium, so that our sweat contains very limited amount of sodium chloride and water. Now if I just put a cross here, then you can see the fact that both salt, that is sodium, and chloride, both are not going to be reabsorbed. So the sweat of these patients will be having a higher concentration of both sodium and chloride. Now, when a mother is going to kiss this child of cystic fibrosis, she might say salty texture of the skin. So you would have read about salty baby syndrome. Like, if you Google the word cystic fibrosis, a lot of these websites, non-medical websites, I would say, they use the word salty baby syndrome. Why? Because there's more salt, that is more sodium in the sweat of this child. So when the mother kisses the child, she finds the texture of the skin relatively salty. So therefore, I come to the eighth manifestation of the disease. Yes, that is sweat glands. The sweat glands are not able to reabsorb the salt and the chloride properly. So in these patients, in cystic fibrosis patients, there is more salt, there is more chloride, and obviously the water component is anyway gonna be there. I mean, salt is gonna hold up the water also. So especially if a person of cystic fibrosis is exposed to hot environment, then unlike a normal person who will cool his body on sweating, here there will be excessive loss of all of these. Therefore, due to loss of salt from the body, these patients would be having RAS system getting activated. The elevated RAS or the stimulated RAS will upgrade the value of aldosterone, and aldosterone then acts on the kidney. This is what aldosterone does. It tries to get back more salt and more water in the body, but it also pays a price that it loses potassium and it loses hydrogen. Therefore, what you can see in these patients is, one, they are losing chloride in the sweat, they are losing potassium and hydrogen with respect to the urine. So the manifestation that is written in the multiple choice question will be written as hypochloremic. Why hypochloremic? Because there is more chloride content in the sweat. It is not reabsorbed like a normal one. The CFTR in the sweat gland is malfunctioning. The secondary hyperaldosteronism that occurs in this patient will result in development of hypokalemic, the exaggerated urinary loss of potassium, metabolic alkalosis. So remember this complete statement: hypochloremic metabolic alkalosis is a feature found in patients with cystic fibrosis, especially in a hot environment. I would just like to invest another 30 seconds into explaining part number 8 again, and I'll just show you the diagram so that we can understand this better. Yeah, I'll just zoom it in. You can notice the fact that normally in the sweat gland, chloride as well as the epithelial sodium channel actively take back the chloride and the sodium. In this condition, the CFTR malfunction occurs. The ENaC component will also be affected, and the combination of the two is seen in cystic fibrosis. Now, how that ENaC malfunction occurs in the patient is still a puzzle for most of the doctors. So you will find a lot of theories floating around for cystic fibrosis. So I would say like this, that in spite of the intensive research we have done, we are not very clear about the pathogenesis of this disease in the exact sense. Yeah, obviously electroneutrality, luminal charges and concepts like those are given, but what happens in the sweat gland is different from what happens in the lung, and that is the main reason why the chloride in the sweat is more. Otherwise, if you were follow the explanation given for lung, chloride in the sweat should have been lesser. So I hope I made a point here. The chloride in the sweat is higher in these patients, and along with that, obviously the sodium component. Due to this, you will notice in the book or you will read that in these patients there could be frosting of the skin, salty baby syndrome would be manifest. The word frosting of the skin is explained by the fact that the sweat contains more salt and more water. So when the water component will evaporate, the salt will be all stuck on the skin. So frosting of the skin. And the mother kisses the child, she says the child is very salty. And then because of the chloride loss, because of the secondary hyperaldosteronism, you would be having a metabolic alkalosis in these patients. The way our body reacts to hot environment and the way their body responds to hot environment is same in a sense that sweating is more, but the contents inside the sweat are different. So therefore, the metabolic alkalosis component can be seen in these patients. And in fact, this is the second most important point for this topic that we're studying today, that after, I would say, meconium ileus, or rather absence of vas deferens that I was explaining earlier, metabolic alkalosis is the important statement from my side for this patient. Therefore, once we have identified these patients on clinical grounds, that is a combination of lung involvement, GI involvement, then steatorrhea, malabsorption syndrome, cirrhosis in the liver, genitourinary involvement in these patients would be in the form of infertility, as has been explained. So let us now summarize the diagnostic criteria for cystic fibrosis. First of all, you should be having presence of typical clinical features. The typical clinical features would be respiratory involvement, which could be in the form of development of either features of COPD initially. Then there could be development of suppurative lung disease in the form of bronchiectasis in the patient, which will obviously take some time to occur. The gastrointestinal manifestations can be in the form of first meconium ileus, which is the early one, and subsequently development of malabsorption syndrome. The malabsorption syndrome can range from something like osmotic diarrhea to steatorrhea occurring in a patient. And the genitourinary manifestations are in the form of a cervical mucus plug or azoospermia in the patient. So if you are having these typical clinical features, or he says there is a history of cystic fibrosis in the sibling, that's very understandable, autosomal recessive consanguinity given in the question. So history of cystic fibrosis in the sibling, or a positive newborn screening test. Now the third point I would like to say for India is a little far-fetched, because in India facilities are less, but when we look at the Western information, they do newborn screening tests for identification of phenylketonuria, congenital adrenal hyperplasia, maple syrup urine disease, and cystic fibrosis. So in case any of the three things are positive, like the Indian possibility will mostly be clinical features or a presence of a consanguineous marriage with a brother or sister having a same disease. From American perspective, there could be a presentation of a positive newborn screening test. So the person should be then subjected to certain investigations that we need to understand. And one of the basic investigations that is done in this patient is obviously sweat chloride. So if you are having sweat chloride in excess of 60 milliequivalents on 2 consecutive separate days, and ideally should be done from 2 separate laboratories just to increase the reliability component. So 2 times if you're demonstrating that the sweat chloride values is more than 60, then it definitely indicates it is cystic fibrosis. Another way to do this is to go in for DNA sequencing and identify 2 cystic fibrosis mutations present in a patient. Or the third test is nasal potential difference test. So there are 3 investigations which are available for this patient. The investigations are going to be as follows. So let's just look at it. Clinical features should be present, or family history should be there. Like he says, the mother says that my one child has expired due to lung disease, was turning out to be cystic fibrosis, kind of a history, and there's a consanguinity in the family. Then obviously I'll think in terms of cystic fibrosis, or there's a positive newborn screening test with the laboratory evidence being any of these to be positive, either to be sweat chloride, it could be a transepithelial nasal potential difference, or DNA testing should be present. That is when we identify or we diagnose cystic fibrosis, also called as mucoviscidosis. So let us just have a look at the workup of these patients. In the left image, you can do a test being done in the patient to identify the concentration of elevated sweat, where we apply these electrodes. And the method that is given here can be asked in an image-based question as what testing is being done in this child who is having recurrent lung infections. The test that is being done here is sweat chloride, and the method that we use is called as pilocarpine electrophoresis. You know that pilocarpine is a cholinergic compound that will activate the post-ganglionic fibers related to sweating, and the sweat that is then collected is then evaluated for the ions in it, which would obviously be higher than normal sodium, higher than normal chloride, and we will be able to identify the disease. So the first workup of these patients would be to perform a sweat chloride level. This should be more than 60 milliequivalents at least twice, that is on 2 consecutive days. You can do it from 2 different laboratories just to increase the reliability component in the patient. The only problem is that you can have a false positive sweat chloride. You can have a false positive sweat chloride value to be more than 60 with respect to certain endocrine diseases, which I want you to remember for MCQ. So one is anorexia nervosa. That would be obviously a person who could be inducing vomiting and is avoiding food on a long-term basis with a body mass index of less than 18. Then could be Addison disease. That's important point to be remembered. Then another condition is congenital adrenal hyperplasia and nephrogenic diabetes insipidus. So false positive can be found with at least 4, should be remembered. So there's a huge list. I've just put the MCQ one important ones: anorexia nervosa, Addison disease, congenital adrenal hyperplasia, and nephrogenic diabetes insipidus. The reason for false negative sweat chloride value would however be relatively less commonly asked. One of the important cause for this is malnutrition, and most of these kids are malnourished because of the growth issues occurring in these patients with respect to osmotic diarrhea and steatorrhea. The false negative can also occur with respect to edema in the patient. So I would like you to focus more on false positives for sweat chloride as compared to false negatives, which are malnutrition, edema, and are straightforward. Then another test that can be done in the patient, that is if he says in the question that it is equivocal reporting. What I mean by equivocal reporting is that report number 1 that came from a particular lab was having a sweat chloride of, let me say, 50, and report number 2 that came from a different laboratory is giving a sweat chloride of, let me say, 65. Now you are stuck because you know whether to take first report as more accurate, second report as more accurate. So the test to be done in these circumstances, if you have a equivocal, that is a non-confirmatory, or I would say a non-conclusive sweat chloride test, then the test number 2 to be done in the patient is called as transepithelial nasal potential difference test. In this transepithelial nasal potential difference test, to be evaluate obviously the name is self-explanatory, nasal potential, with respect to the nasal secretions in the patient. This is a very peculiar name, so you just have to remember like this only. They'll not ask you the technical details of it, how it is done, but then transepithelial nasal potential difference test, when is it done? In cases of equivocal sweat chloride report. And the third way to identify this particular disease is going to be answered as DNA testing. In DNA testing, we can identify the mutations which are responsible for this. So we need to demonstrate at least presence of 2 mutations so that we are sure about our diagnosis in this patient. The fourth investigation that would be done would be fecal elastase levels. The reason for doing fecal elastase levels is to identify the malabsorption component of the disease. I will also do a pulmonary function testing because in the initial part of the disease, you will be having spirometry readings of obstructive airway disorder. But in the later part of the disease, there would be pulmonary scarring, so the patient will be having interstitial lung disease features or restrictive airway disease manifestations developing. Pulmonary function testing is important, especially for decision with respect to pregnancy, because if the pulmonary function test report is showing a low total lung capacity or reduced time to vital capacity, then the chances of continuing the pregnancy would be not a good idea because it can interfere with the life of the mother. These patients can develop diabetes mellitus by second decade of life, so HB1C would be done. This can identify secondary diabetes mellitus. The seventh investigation would be a X-ray chest and HRCT chest, the images of which I have already shown to you with respect to bronchiectasis and dilated airways in the patient. Sputum culture must always be done so that you can identify the colonization of the airways of the patient. And the usual organism which is responsible for colonizing the airways of these patients is Pseudomonas. Though the first infection occurs with Staph aureus, subsequently Pseudomonas predominates. It forms a biofilm in the lung which is literally impervious to antibiotics, and therefore the infection rates are definitely high. Before we go into the treatment of this condition, I would just like to show you regarding aspects related to metabolic alkalosis. So one of the important causes of hypokalemic alkalosis to be remembered before you is cystic fibrosis also. Most of the time you could be having a metabolic alkalosis secondary to nasogastric tube loss, Usually the question that has been asked in the exam is what type of metabolic derangement is found in patients who are having excessive nasogastric tube loss. The answer is metabolic alkalosis. Why? Because when you are having excessive nasogastric tube losses, there will be dehydration in the patient that will activate the RAS. An activation of RAS will upgrade aldosterone, and aldosterone will lose potassium and hydrogen through the kidney. So there would be a metabolic alkalosis developing in a patient. But today I've told you that even cystic fibrosis contributes to metabolic alkalosis in a patient. Then obviously there could be rare conditions of tumors, or there could be rather polyps which are causing chloride loss. There could be chloride loss secondary to excessive diuretic usage, and Bartter and Gentleman syndrome is what I've discussed with respect to the topic of the kidney. So Bartter and Gentleman syndrome can be studied separately. They will affect like Bartter syndrome affects the thick ascending limb of loop of Henle, and Gentleman syndrome affects the distal convoluted tubule, and even from these areas the transporters which are present help in absorption of chloride. So if these transporters are defective, then the chloride reabsorption will be lesser and you lose chloride from the body. So what are the causes for hypochloridemia that I've explained to you? Normal chloride in the body is between 96 to 106 milliequivalents. Conditions in which chloride in the body will be less than normal have been discussed today. Chloride in the body can be less in Bartter syndrome and Gentleman syndrome, diseases related to thick ascending limb of loop of Henle and distal tubule respectively. Then there could be polyps in the gut which could be losing excessively or exclusively chloride. Diuretic abuse can also contribute to hypochloremic alkalosis in a patient. Then would be excessive NG tube aspirate. And last but not the least, the topic of our interest, cystic fibrosis, also contributes to hypochloremic alkalosis in a patient. So all of these conditions not only contribute to hypochloremia but also contribute to alkalosis secondary to secondary aldosteronism that will occur in these patients. So I would like to list out these causes as causes of hypochloremic metabolic alkalosis in front of you, starting from Bartter Gentleman, polyps in the gut, diuretics, NG tube aspirate, and cystic fibrosis in the patient. Now, once we've done the workup of these patients, it is time to talk about the treatment. Talking about the treatment of this particular disease, one of the very important steps that is to be done for management of these patients is to use a product that will make the lung secretions relatively thinner or the consistency relatively better, so that antibiotics can go in and the patient can cough out the secretions also. So we use human recombinant DNA technology, and with the help of this technology we are able to synthesize what is called as DNase or dornase, and this will decrease the tenacity or it will reduce the viscosity of the sputum, and therefore the antibiotic penetration and the ability of the patient to cough out the secretions will be relatively better. In those situations where we are not able to procure DNase for the patient, we also use N-acetylcysteine, and we usually follow it up with a beta-2 agonist nebulization, which improves the oxygen saturation of the patient. And once the airways get dilated, the patient can then develop stamina, because airways are dilated, more oxygen is going in, so person will develop stamina to cough vigorously and expectorate the sputum. In our government hospitals, we also used nebulization with hypertonic saline. You can go up to 7% hypertonic saline instead of standard 3%. We can go up to 7% hypertonic saline, and the secretion or the logic behind this is the hypertonic saline will again draw water into the periciliary fluid and into the mucus. So once it will draw water, then the consistency of the tenacity will become relatively lesser. Americans have better response or better management track record with respect to this disease, because in America what they're doing is that on a weekly basis they're nebulizing their children with tobramycin. So if you are going to do a nebulized tobramycin, it will prevent the colonization of the airways by the dangerous organisms like Pseudomonas that can form a biofilm in the lung of the patient. So nebulization with aztreonam and tobramycin on a regular basis will reduce the chances of colonization. Once I have ensured that the sputum consistency is lesser, then we will do chest percussion, chest physiotherapy in the patient, and encourage the patient to cough out the lung secretions. We also have commercial devices available. These commercial devices would be contributing to the oscillations or percussion, like it's a mechanical way of percussion in the chest, hand-held oscillatory devices. The vibrations which are produced by these devices will again help in mobilizing the lung secretions out and the person can cough them out. One of the dangerous organisms whose colonization is now being asked is Burkholderia cepacia. This also forms a biofilm in the lung, and the antibiotic of choice for this has been asked in the exam, so I thought I'll just mention it here, because if a person is having a pneumonia and the transtical culture and aspirate shows Burkholderia, then I will be using meropenem for management of these patients. The eighth point of mind for these patients is use of steroids. Looks very surprising but true, because a lot of these patients can be having upper airway colonization by aspergillus. They can be developing thick tenacious sputum due to colonization and hypersensitivity reaction to aspergillus, which is present in the normal environment. So aspergillus can contribute to aspergillus aspergillic bronchopulmonary aspergilloma, and this ABPA responds to obviously usage of antifungal drugs like itraconazole, but steroids are also given, because when you are going to have a hypersensitivity reaction to the organism aspergillus, then to reduce the hypersensitivity reaction, steroids will be used. ABPA is allergic bronchopulmonary aspergilloma. This is seen with the topic of interest, that is cystic fibrosis, and also with asthmatics, and you can go down into the infection segment where I have discussed regarding aspergillosis, and ABPA is an important disease which is asked in the exam, so I definitely want you to remember. And one of the highlight features of allergic bronchopulmonary aspergilloma to be remembered is central bronchiectasis. Because normally we read about bronchiectasis involving only the lower lobe, or let me say in cystic fibrosis maybe only the upper lobe, but central bronchiectasis is very characteristic. It is a colonization of the central part of the lung that is seen with aspergillus, and the test that is done for these patients is serum precipitin or antibodies against the aspergillus species. We now have a new drug for management of cystic fibrosis, and that is one reason that I've gone into the treatment part of this, that is by the name of ivacaftor. Now, ivacaftor does not act with respect to F058 mutation, but it acts with respect to what is written as G551 mutant protein. This CFTR, like I said, there are a lot of defects with respect to CFTR. So the G551 mutant protein has a defective chloride conductance. Due to the loss of the chloride conductance, what happens is that the secretions are having less water and they're also acidic. What we have shown in studies is that if ivacaftor is used regularly in the patient in an oral dose of 150 milligram twice a day, then it causes improvement of chloride conductance. This mutation is responsible for loss of chloride conductance. Ivacaftor does this improvement of chloride conductance, so the advantage is FV1 increases with usage of ivacaftor. The pulmonary exacerbations or the lung manifestations of these patients will definitely begin to reduce. So we have a long way to go before we are able to effectively manage this patient. Obviously, for perinatal diagnosis, we have techniques like this baby can be prevented from being born by using techniques like chorionic villus sampling and amniocentesis, and the baby with cystic fibrosis will never be born. In fact, in America, the incidence is going down because they're effectively using prenatal diagnosis as an effective technique in the form of chorionic villus sampling or amniocentesis, and prevents the children to be born. But in India, where women don't even seek routine obstetric care, the diagnosis of this condition before birth is definitely a challenge, and the parents spend a lot of money in taking care of the child with respect to multiple interventions that are to be done, the diagnostics which are to be done for these patients. So this is a disease which has a high level of mortality, especially in our country. Though in America, these patients will go up to adult age group and might even have relationships, in a sense that they would be having normal sexual functions, especially men and women can have normal sexual functions, but the chances of conception in these patients will definitely be reduced. So these are the details for this topic, mucoviscidosis, that I want you to be thorough with, and keep hammering, keep working, and I'm very sure you're going to come out with fine results. Thank you so much for listening.